Hi, everyone. Welcome. I'm Ellen. I'm MDeverywhere's Marketing Director. For those not familiar with MDeverywhere, is the single source RCM and EMR solution provider with technology and best practices, billing services proven to improve claims process, increase denials, and increase collections for our clients an average of 10-15%. I do want to thank you for joining us today for our webinar on understanding the 2014 EHR Incentive Program. Our presenter, Kristen Heffernan, she's Shine Micro-D's Director of Product Management and Marketing, and we are excited to have her share her expertise with us today. As a product manager, Kristen is current on evolving regulatory requirements and government-sponsored programs, such as the CMS EHR Incentive Program, to ensure that EMR software can assist providers in meeting requirements and to educate clients on changes. With 15 years of marketing experience in the healthcare industry, it's her job to understand this EHR incentive. She's going to share that knowledge with you today. Before I go over to Kristen, let's cover a couple of housekeeping points. This webinar is being recorded. The recording will be shared with registered via email. We'll also share a copy of the PowerPoint presentation as part of our follow-up process with those who would like it. While attendees will be muted during Kristen's presentation, we have allowed time for Q&A and encourage you to participate by typing your questions into the questions window on the control panel as you think of them. We will answer as many as we can during the presentation. Any that we don't have time for live will be followed up with individually. We're also going to be posting 3 survey questions during this presentation. So when those do pop up on your screen, we'll invite you to participate and enter your answers. Further delay, I will hand over the mic to Kristen Heffernan for her knowledge that will help you better understand the 2014 EHR Incentive Program. Kristen?
Thank you, Ellen. I'd like to welcome everybody to today's webinar. We have a lot of ground to cover today, so I'd just like to take a moment to start by recapping the focus of today's webinar. So today's webinar is intended to provide objective information for non-acute providers, practices, and clinics on the combined 1,000 plus pages of the Stage 2 final rule for the CMS EHR Incentive Programs, and that's specific to eligible professionals. This will not cover the hospital-focused program. This is more focused on individual providers in non-acute care settings and that program. So today we're highlighting the changes to Stage 1 meaningful use requirements, as well as a lot of the new requirements for Stage 2 for providers that are either just starting their journey to secure CMS EHR incentives, and for those that are continuing down the path of meaningful use, either in Stage 1 or going into Stage 2 this year. So if you're a provider, if you work with a provider, or you're part of an organization that's affiliated with a professional who's eligible for one of these programs, we're going to get started. First, walk through the agenda today. For some of the acronyms that are specific to the CMS EHR Incentive Programs, we will do a program overview, both the Medicare and Medicaid versions of the program. I will touch on an overview of Stage 1 and what Stage 1 meaningful use requirements focus on, as well as then getting into some of the items that are in the Stage 2 final rule. So having an overview of what Stage 2 brings to the table over and above Stage 1 requirements, as well as talking through some of the changes to Medicaid eligibility that are outlined in the final rule, and changes to Stage 1 that are also outlined in the final rule. And then I will get into the specific Stage 2 objectives and some of the clinical culture guidance that's provided in the final rule, and then touch on payment adjustments and exceptions. And those payment adjustments tied back to the Medicare program. So it's a delicate balance here where providers have the opportunity to participate in the EHR incentive program, to earn some of the incentives to cover the cost of implementing EHR. But they also, if they do not choose to participate in a program as a care provider, they could be subject to payment adjustments starting in 2015, and we'll talk about what those are. We'll talk a little bit about what providers should be doing to prepare to participate in an incentive program, either as a new provider or continuing on within Stage 1 or Stage 2 starting in 2014. We'll wrap up today's webinar talking about MicroMD's commitment to what we're doing on the software side to enable providers to secure the incentives. We'll touch a little bit about MDeverywhere and how the focus on the revenue management is assisting providers as well, and then wrap with Q&A. So the first thing to touch on is acronyms, and we have in healthcare, so we know that there's an acronym for everything. The brunt of the joke with my family is that I now speak in acronyms. People don't understand me. People that I work with do. So there are, yes, a number of acronyms tied to the CMS EHR Incentive program, and I'll highlight some of these. EP, which is eligible professional, that is a provider that is eligible to secure incentives from one of the incentive programs. MU stands for meaningful use, and that is the required ways that providers need to utilize EMR certified EMR software based on the stage of meaningful use that they're participating in. Clinical quality measures is one of the sets of data that needs to be recorded and tracked to be able to attest to secure the CMS incentives. We'll talk a little bit more about those. The acronym, or the letters AIU, stand for Adoption, Implementation, or Upgrade, and that is specific to the Medicaid Incentive Program. And the Medicaid Incentive Program gives providers a little bit of a break the first year that they participate in the program. They're eligible to actually secure incentives for the first-year program strictly by proving that they adopted, implemented, or upgraded to certified EMR technology. CMS, we're all familiar with what that term is. CMS actually manages provider requirements for use for these programs, and CMS partners with ONC, which is the Office of the National Coordinator, and the ONC establishes the other half, the requirement that EHR technology needs to meet in order to certify the program. The Standard and Certification Criteria is an organization that establishes ultimately the certification process for 2014 edition EHR technology. That's the new criteria, the new certification that HRs need to have starting in 2014 to allow providers to continue with meaningful use or program. ONCPCB is another fancy acronym, and that is essentially a testing body that CMS and ONC have approved to test and certify EMR technology, so that EMR technology needs to be certified according to standards and certification criteria and certified by an ONCACB approved testing body. And then the last acronym is CERT, certified, and that stands for Certified EHR Technology, and that's a short term for having that EHR certification. And a quick note before I move on, when you start really want to answer technical questions or detailed things regarding any of the CMS EHR program, the best place to go and look is do a word search, CMS EHR Incentive Program website. That will pull up first and third term, and that has all of information about Stage 1, Stage 2, attestation, the differences between the Medicare and Medicaid programs. So that's a very good resource for information. So let's move into an overview of, I'm sorry?
Let's do a quick pause. We're going to do our poll, and let's find out from the audience. That's okay. Does your EMR vendor offer a 2014 edition certified version? Right? If you would participate, yes, no, or don't know. It'll take about 15 seconds here to give you some time to fill in your poll answer. If you're using an EMR, your EMR vendor offer a 2014 edition certified version. We're getting back some real responses. All right. We're going to close the poll. And Kristen, get going again.
All right. Continuing on, let's get into an overview of the CMS EHR Incentive Program. Really, where did it start? And it's born out of the Recovery and Investment Act, or ARA Act, of 2009. People know this as the stimulus bill. And just like the stimulus bill, funding available on a federal level for road improvements and educational improvements, it also allotted a healthcare IT portion, essentially referred to as the HITECH Act. And that act, part of the stimulus bill, allocates billions of dollars of incentive money to providers, hospitals, and other resources to assist providers in ultimately achieving HITECH Act goals. And the goal of the HITECH Act focus on improving quality, safety, and efficiency of care while making sure that people have access to it, getting families and patients engaged in health care, boosting the role of public and population health, providing more data that they can utilize to make better large-scale decisions, improving the coordination of care across all different referral areas, and promoting the privacy and security of health information. So there's some areas that are tied back to HIPAA requirements within the ARA Act, that HITECH Act portion of it. And the thought of being able to fund the incentive program for EHR is that EMR really help providers achieve these goals. So that's where it all originated. And we're going to compare and contrast and look at the stages of meaningful use. The incentive program is broken down in stages. Each stage has different payment years associated with it for the incentive payments, and different stages of meaningful use. And again, we already mentioned that meaningful use is the required ways that CMS outlines that providers need to utilize the EHR technology in order to secure their incentives. And each stage, there are 3 stages, has different requirements. Stage 1 meaningful use requirements have been in place since 2011. Stage 2 requirements for providers that are moving into that stage, those providers that have completed 3 or 2 years of Stage 1 meaningful use already, in 2014 they'll start in using EHR technology according to Stage 2 meaningful use requirements. So that's what you're seeing up on the screen today. Any providers that would be starting fresh in 2014 for the first time with an incentive program would complete 2 years of meaningful use underneath the Stage 1 requirements, and then starting in 2016 they would go into Stage 2 meaningful use requirements and utilize the software at that point in year 2016. And I wanted to take a moment as well to compare and contrast the 2 incentive programs. Medicare has its own program, which is a federally based program. Medicaid, each individual state can decide whether or not to participate in the incentive program and offer incentives. And they also have different rules surrounding eligibility, the payment schedule, and the total payment amount. So what you're looking at on the screen is the Medicare payment schedule. And what the key point to focus on is, for providers that would be starting new in 2014, while they're not eligible for that full amount that was available to providers that started in 2011 or 2012, they're still eligible for a total of $24,000 over the remaining life of the incentive program. And in many cases, that helps balance out what we'll talk about later in the webinar are the payment adjustments that Medicare will be implementing starting in 2015 for not meeting meaningful use. And the converse to the Medicare payment schedule is the Medicaid payment schedule. This is a little different. This program does allot, regardless of the year that a provider starts, will allot a total of $63,750 over the course of the program. And then if you notice, providers starting in 2014 would be eligible for that full amount throughout the life of the program. And then the last year that a provider would be able to participate in the Medicaid version of the program would be in 2016. in order to be able to secure the full amount of the incentives that are available. So let's move on to an overview of Stage 1 meaningful use requirements, and we'll compare and contrast Stage 1 at a high level with Stage 2 requirements. And the Stage 2 final rule that was released back in 2013, Stage 2 really outlines what are the requirements for meaningful use starting in 2014. And that could be a change to Stage 1 requirements and also outlines the new Stage 2 requirements. Stage 1 focused more on the capture of electronic health information. So having an EMR to start tracking key clinical conditions, capture data, being able to communicate information for care coordination, such as being able to quickly and easily export a standardized electronic healthcare record for another provider that you're referring a patient to. It also required the reporting of clinical quality measures and is looking for providers to start submitting information to public health entities. And in Stage 1, the meaningful use requirements, there are 20 objectives or requirements total measures. 15 of those measures or objectives are core, they are mandatory. There are also 5 additional menu set objectives that providers need to select from a list of 10. Those 5 are mandatory, but they have a little flexibility in which 5 they can do out of that list of 10. And now contrasting Stage 1 with the final rule for Stage 2. And again, this is that 1,000+ page document that CMS and ONC released, and it outlines a number of different things. So it officially delayed the start of Stage 2 until 2014. Originally it was to begin in 2013. The final rule also established new requirements for meaningful use by payment and stage, payment year and stage, and outlined the requirements that EMR technology needs to meet starting in 2014, which is different from what they needed to meet starting in 2011. So EMRs need to have a new certification, which is called the 2014 Edition certification. The final rule also outlines some positive changes to Medicare provider or Medicaid provider eligibility and shores up the payment adjustments and exceptions that Medicare will be implementing for providers that don't meet meaningful use. And the final rule also touches on changes to Stage 1 meaningful use. So although the Stage 1 meaningful use requirements were originally outlined in 2011, 2014, as a result of having the program run for a couple of years, the final rule for Stage 2 outlines some changes that providers need to meet when they're doing Stage 1 meaningful use that start in 2014. And we'll talk about what some of those are. Most objectives have remained unchanged for Stage 1, although some thresholds may have been raised. Some objectives have been eliminated or combined, and then there is a change to how to report clinical quality measures for starting in 2014. And the big area of the final rule for Stage 2 outlines the new Stage 2 meaningful use requirements. So those are new to the industry. Providers that are going into Stage 2 starting in 2014 or beyond would need to be meeting those requirements. And those Stage 2 requirements, remember we said there's 3 stages of meaningful use. Stage 2 requirements build on the Stage 1 requirements. So it asks the providers to do a little bit more, to capture a little bit more information. There is a change in the number of objectives that providers need to meet. And there are some new objectives that providers will be seeing in Stage 2. And Stage 2 at a high level, again, we talked about the fact it builds on Stage 1. It really focuses on being able to improve the exchange and access of health information by patients, by referring providers, by the existing providers. And it expands the requirements for meaningful use, and really ultimately is getting towards the goal of moving up beyond just collecting the data in the EHR system, but now being able to take that data and slice and dice it and report on it, to be able to use that data to make broader healthcare decisions to ultimately improve quality, efficiency, and patient safety, which, if you'll remember, is one of the goals of the HITECH Act that was set up to fund the EHR Incentive Program. And for stage 2, providers needing at least 2 years of stage 1 would go into stage 2 in 2014. They would begin that journey. And a little bit different in terms of the number of objectives and the breakout of the objectives. While they still need to meet 20 total objectives, in stage 2, they're broken out a little differently. So in stage 1, there was 15 core objectives. In stage 2, there are 17 core objectives. Those are mandatory. And then on the menu set objectives, whereas stage 1 was selecting 5 menu set objectives from a list of 10, CMS has now limited this a little bit to choose 3 menu set objectives selected from a list of 6. So let's jump into what are some of the true changes that are occurring that show up in that stage 2 final rule. The first of those is a nice one for Medicaid providers, and it expands the eligibility for providers to participate and be an eligible professional in the program. So a couple of the two biggies underneath that is that now the eligibility counts will apply for anyone that's enrolled in a Medicaid program. Stage 1 only allowed patients to be counted if there was actually a paid Medicaid claim, but we all understand that some low-income folks where they're comping some of that care may not actually submit a claim for it. And then zero pay claims are applicable to that eligibility count, so more providers can become eligible. Another important focus of the stage 2 final rule are outlining changes to stage 1 meaningful use requirements. And as we start getting into some of these upcoming slides and the specifics of stage 1 meaningful use requirements and stage 2 meaningful use requirements, there will be a lot of information on these slides, although what I'm going to do is highlight maybe a key piece of information on each in blue that I'll talk about. As Ellen mentioned, you will receive a copy of today's slides that you can review the additional details at your leisure. Again, we talked about some good reading material. If you're looking at something to read or sleep to at night, you may want to even go back out and read the 1,000-page plus final rule, which is actually a good thing to do to understand the depth of the program and what providers are required to do. But let's get back to the changes to stage 1 meaningful use. And one item that has actually changed is for the stage 2 meaningful use requirement, there have been some changes to an optional measure. So they've added an additional measure for being able to report CPOE and meet that core objective. The measure that they originally outlined in stage 1 was prohibiting a number of providers from actually meeting the measure. So now they're offering 2 ways to meet the measure. So that's a nice change that they've offered to stage 1. Some of the other things that they're doing is requiring some increase of thresholds for some of the counts, for some of the elements, requiring providers to on the clinical quality measure piece, case in point, is no longer considered a separate core objective underneath stage 2 meaningful use, but providers still need to submit clinical quality measures in order to be able to attest or say, yes, I have tracked these CQMs, and be able to submit and secure their EHR incentives. So there's a number of changes to stage 1 meaningful use that you can review at your leisure. And the final rule also outlined stage 2 meaningful use objectives. And as I had mentioned, there's a number of different things that have happened from stage 1 to stage 2. So as providers complete their stage 1 requirements, they've been successful at meeting those objectives. Now providers move into stage 2, and the stage 2 meaningful use objectives build on stage 1 requirements. So what they've done with stage 2 is there are a number of objectives that remain the same. Case in point is performing a medication reconciliation for more than 50% of patients that are transitioned into the care of an EP or eligible professional. So that's an unchanged objective. There are a number of those. And stage 2 also has a change to some of the existing stage 1 measurement thresholds. or a redefinition of a Stage 1 measure. So it's not that the Stage 1 measures have transferred perfectly over to Stage 2 and remain the same. In some cases they have, which we just looked at, but in some cases they have upped the ante. So case in point for a measurement threshold that has increased is providers need to generate and transmit permissible prescriptions electronically, electronic ERX prescriptions, now for 50% of patients, and that is up from the 40% measurement threshold that providers needed to do in Stage 1. Same situation for recording smoking status. Now that needs to be recorded for 80% of patients and not just 50% that the providers needed to do in Stage 1. There's been some redefinition of some measurements in addition to those, and one of those here that I'll touch on as the first bullet point is in Stage 1, the core objective was to conduct a security risk analysis to ensure that data, sensitive healthcare information is encrypted and secure. So Stage 1 just required the providers to do the risk analysis. Stage 2 actually requires the providers to implement corrections for any identified deficiencies. So that's a second piece of what's required for Stage 2. Some objectives from Stage 1 have been combined and reinvented, as I call it, a Franken objective in Stage 2. So if we look at the core requirement for being able to provide a summary of care document at all transitions of care and referrals, where now it encompasses being able to include the up-to-date problem list, medication list, and allergy list as part of that summary of care document in Stage 2. In Stage 1, the medication list, the allergy list were all part of something else. So now they're combined into having those available in that summary of care document that providers would need to provide to referring professionals. Some objectives have been eliminated from Stage 1 to Stage 2. Case in point, we hit on it a little bit ago, is that clinical quality measures are no longer considered a core or mandatory objective, but they still need to be reported for when EPs go to a test for meaningful use. So ultimately, those CQMs now get reported as part of PQRS, but the provider that's participating in the incentive program still needs to say, yes, I have submitted my clinical quality, I've tracked my quality measures and I've submitted those. And there are some new core objectives for Stage 2. And one of those being provide patients the ability to view online, download, and transmit their health information. Well, that's not completely new necessarily from Stage 1. There are some big new areas in there. And the key point with that one is that being able to give patients the ability to log on somewhere, securely access, be able to download their own electronic health record, and then transmit that health record electronically to a provider in a secure manner. And most of the time that is all enabled through a patient portal. So that would be a new thing that many providers might come into contact with if they've not already implemented a patient portal that will allow them to do this. That would be something that they might need to be doing in conjunction with their certified EHR technology in Stage 2 starting in 2014. There are also some new menu set objectives, and there's 5 new ones that are here. Again, we talked about the fact that providers need to select 3 from a list of 6, and some of the new menu objectives are listed here, such as recording an electronic progress note within the patient's electronic health record. The Stage 2 requirements and the final rule outlines changes for the clinical quality measures, as we talked about, and providers that are in payment year 2 and beyond, number 1, will need to report their clinical quality measures electronically for Stage 2. So that is a change, something to keep in mind. And then there are requirements for reporting those depending on whether the provider is participating in a Medicare or Medicaid program. And there's some guidelines for selecting and the number of clinical quality measures that the provider would need to track and attest to for the CMS EHR Incentive program. For the program, providers need to submit reporting that they have tracked 9 clinical quality measures from a total list of 64 that are available. 3 of those quality measures need to be selected from the 6 national quality strategy domains that are listed on the slide. And again, if you go to the CMS EHR Incentive Program website, you can download information on all of these 64 specific clinical quality measures, as well as which national quality domain that they fall in, so that you can make those decisions there and submit that information electronically if required, along with PQRS data. And the next slides that I'm going to click through very quickly really are more for, again, your reading at your leisure. I listed out each of the Stage 2 core objectives, again, those 17 total that are mandatory. Some of them are a little long. And I've also shared with you the 6 total menu set objectives that providers need to select 3 of those 6 to meet. And let's move on, shift gears a little bit from the detailed requirements of Stage 1 changes as well as the Stage 2 meaningful use requirements to talk a little bit about payment adjustments and exceptions. And those are, at least at this point, specific to Medicare providers. So what it really states is that Medicare EPs, anybody that's eligible to participate in an incentive program who are not meaningful users, by ultimately 2014, will be subject to a 1% payment adjustment in their Medicaid payments starting January of 2015. That number continues to move or increase, that percentage payment adjustment for providers that aren't meeting meaningful use in 2015. 2014 or 2015. In 2016, they'll be hit with a 2% payment adjustment. So that goes back to highlighting again the discussion that there are incentives available, and it makes sense for providers to start participating today to take advantage of those incentives that are available and avoid the quote-unquote disincentive, although that's not what Medicare calls it, that starts in 2015. And it really gets providers in the habit of improving their documentation, which will also be something that's very good, tying back to the ICD-10 transition that will be happening in October of this year. Having EMR in place for that ICD-10 transition really almost will become a requirement, because if you imagine trying to manage the volume of ICD-10 codes and that process in a paper environment when that transition hits, will be very challenging. So those payment adjustments do have some exceptions that Medicare has outlined. So the exceptions will be granted if CMS determines that circumstances pose a significant barrier to achieving meaningful use. So new eligible professionals are given a 2-year exemption. Obviously, a natural disaster would provide an exemption. Or certain specialist or provider types maybe have an exception to those payment adjustments. In cases where there's a lack of face-to-face connection with those patients, there's no need to follow up, or for providers that don't have control over whether EHR technology is available at their practice location. Those exceptions in those particular cases do need to be applied for, although CMS has not fully outlined what that process is yet, but that's something to watch on the CMS EHR Incentive Program website. But then also 3 specialties at this point do automatically meet the exception. They don't need to apply for those. Pathologists, radiologists, and anesthesiologists, as long as their PAYCOS code matches the determined exempt specialties, which again you can find out through CMS what those PAYCOS codes are to see if there is an automatic exception that would be granted. And then let's let's talk a little bit about preparing to participate in a program. And then again, this really applies to both providers that may not have started a program yet, that are eyeing one up and looking to participate, and to providers that are already participating, either in Stage 1 or Stage 2, going into 2014. And what we've seen out in the industry is there is a challenge for EHR vendors to meet all of the new certification requirements that were outlined by the ONC for this program, and all the changes to Stage 1 as well as all of the new Stage 2 meaningful use requirement. The EHR technology needs to be able to be programmed to allow the providers to be able to utilize it in the required ways to meet and report on meaningful use. So what we're seeing today is that only 1 in 8 physicians currently has an EHR that is capable of meeting the requirements for Stage 2 meaningful use. And if you make the comparison between when the incentive programs first started back in 2011, and EHRs needed to be certified at that time underneath the 2011 Stage 1 requirements, back in 2011, over 1,500 EHRs had achieved a complete approved certification for the incentive programs. 1,500. As of today, we're already well into 2014. Only 110 EHRs have their complete 2014 edition certifications. So that should tell you something about how challenging this is for the EHR vendors, but the flip side is you also have the providers that are out there wondering, is my EHR system going to be ready, and when? Because the programs have already kicked off. So some tips on preparing for 2014 CMS EHR incentives, and again, this is depending on whether you're an existing eligible professional already participating in a program, or somebody that would be starting new. So 2014, as a reminder, is the last year that providers can start to participate in the Medicare Incentive Program. Medicaid providers can start up until 2016. But there's 2 different schools of thought here for starting the incentives or continuing with incentives in 2014, either one. Providers that are continuing their journey would need to make sure that they're upgrading their existing EMR technology to a version that has the 2014 edition certification. So this ties back to the slide before where I outlined the fact that 110 EMRs today have their complete certification. So there are a number of EHR vendors that are still not prepared to allow their providers to start 2014 meaningful use, even though the program was available for starting January 1st. But providers should expect that they absolutely, anything that they would do for incentives in 2014, they must contact their vendor, find out if they're going to have the 2014 edition certification and when, plan for when they would upgrade their existing EMR to a certified edition, train for all of the changes, either for Stage 1 changes or new Stage 2 requirements. They would need to complete 3 months of meaningful use within the calendar quarter. So that is regardless of stage or payment year. Every provider starting in 2014 or moving into 2014 would only need to complete 3 months of meaningful use. And then they would attest by February 28th of next year. So there's providers that have not chosen to participate in a program yet, that if they're looking at doing that, they would need to purchase EMR with a 2014 edition certification and plan and execute that implementation project, because it's not easy and it's not quick. But the impact lasts a lifetime if you get the adoption down and that long-term adoption is successful. So allowing time to be able to train on the new EHR that's been implemented, and same thing as anyone that's upgrading is completing the 3 months of meaningful use in 2014. And going into 2015, providers would need to complete 365 days of meaningful use, regardless of the stage or payment year.
All right, let's pause here and give Kristen a little bit of a break. Let's do our second poll question. Everybody can just take 20 seconds. While the Meaningful Use Incentive Program is different than the ICD-10 compliance we'll be facing in October, it is important to know whether or not your practice management and EMR vendors are prepared for ICD-10. So do you know if your PM or EMR vendor is prepared for ICD-10? Okay, leave the poll open for another 5 seconds. And then we will have one more survey question that we'll pose during the Q&A session. All right, Kristen.
All right, thank you. So as we start wrapping up the full content of today's presentation, we did want to tie back to obviously give our plug about MicroMD. You know, as Director of Product Management, Director of Marketing, as Ellen mentioned, my big focus is really on making sure that not only are we building EHR technology to, you know, meet workflow and be more efficient, allow practices to automate more things that they do in their practice, both on the administrative, financial, and clinical side, but also we have to have that commitment to programming and certifying the software across all of the stages of meaningful use, which we are doing. And also, as Ellen had mentioned, you know, there is a tie, you know, we have the whole entire industry has the huge wave of ICD-10 changes that are coming down the pike in October of this year. So that's another thing that you know, your PMD should be focusing on as well, which we are too. So we're, you know, happy to report we have our current 2014 edition complete certification for our EMR. We have a system that is easy to use and configurable. It is integrated with multiple PM and EHR. There are integrated e-services that also tie into both the PM and the EMR, such as Dragon voice recognition technology on the EMR side, different types of credit card, debit, and payment modules on the practice management side, you know, to boost that cash flow piece. We as an organization, MicroMD, has 30 years of medical software experience, and we're backed by Henry Schein. We are a division of Henry Schein, the global parent company that a lot of people I'm sure are familiar with and even purchase supplies from today. And the great thing, again, we have that certification. We're proud of that. With only 110 other EMR softwares out of 1,500 that were originally certified, we're one of those. And we were certified prior to January 1st. So we have a number of clients that we were able to work with back in 2013 to actually get them up and running, get them upgraded to the most current certified version so they could start their meaningful use journey January 1st of this year. So that's one of the things that we do pride ourselves on. And I'll hand this back to Ellen to talk about MDeverywhere.
All right. Thank you, Kristen. And folks, before we do open the floor to questions, remember you can type them into the questions window on your control panel. I do want to mention a little bit about MDeverywhere. We are a bit different than MicroMD in that we provide ICD-10 ready, purpose-built revenue cycle management technology and a full suite of claims processing and back-end services to physicians. Our clients are already working on an ICD-10 ready version of our product, Practice First. So they're already seeing those ICD-10 codes. They're able to do their code lookups. They're getting familiar with those codes. So then we do go in and make that transition in October. They're going to be more familiar and more ready for that. Through our partnership with MicroMD, we do offer the 2014 EHR certified solution fully integrated to our RCM, our revenue cycle management technology, so that we ultimately provide a single source solution for all of a practice's revenue cycle and EMR needs. Additionally, we have an NCQA certified CBO and credentialing division that truly make us a full service company. We service approximately 7,000 physicians nationwide, cover over 40 different specialties, and we really do help them with all their revenue cycle, EMR, and credentialing needs. It's a full service company. I do want to ask the last polling question here, given the information that you have on both MicroMD and EMR. We're going to launch our last poll question. If you would like more information on a 2014 certified EHR, either if you're not using one today or if you're not sure if your EMR is 2014 certified, if you would answer that last poll question now. While we have that running, I do want to let everyone know that this session is being recorded. We will be providing a copy of the recording to you all within a day or so, probably less than that. And we will also be following up and provide you with a copy of the presentation. All right. All right, so we're going to wrap this up, and then we're going to open the floor to questions. All right, let me close this last poll. All right, so we do have a couple of questions that have been submitted, so let's get to those. And again, if anything else comes up, just pop it into that chat window, and we'll get to as many as we can with the little bit of time we have left. Kristen, first question that we have, what do you see as being the biggest challenge to achieving meaningful use in stage 2?
What we're experiencing with our clients is, number one, stage 2 requirements are different from stage 1. There is, as we talked about, an increase in the thresholds. There are new core objectives, there are new menu objectives, and to meet the requirements for those core objectives and menu objectives and be able to report on those, in many cases within EMR software, there are new fields that providers might need to fill in information for, or new things that the providers will be required to do. Again, providing, one of the core objectives is providing that summary of care document for referrals, transitions of care. So that is something that the providers need to do. It may be over and above, in some cases, what they're used to doing. So one of the challenges that we see is, number one, really training the providers to document the information that they need to meet meaningful use requirements within the software, because in many cases it does go outside of what they're normally used to doing. But what has to be remembered is, the organizations, the practices, the providers are participating in the incentive programs that, number one, you want to be able to tie back to those high-tech ACT goals of improving quality, efficiency, and safety of care. Providing patients to more access to health care, engaging them more. Those are the goals of the program. And then additionally, being able to secure incentives to offset the costs of implementing the EMR software and being able to do some of these things that are, so good for patient care in general.
Okay. We have another question. We do have quite a few questions coming in, and we'll get to as many as we can. We have a question, what can providers expect in the way of audits for the incentive program?
And this is a question we're starting to hear more and more frequent. CMS is contracted with a third-party organization that essentially is going to be contacting eligible professionals that have been participating in one of the CMS EHR incentive programs. That third-party organization is contacting the providers directly, giving them guidelines for, how the audit will go, what they need to have prepared, and then ultimately conducting the audits and then determining whether or not providers need to give back incentive money. So what's really important to understand is, again, go to the CMS EHR Incentive Program website, search for information on the incentive program audits, understand who's doing the audits, what are they doing, and really get a handle on what information do you need to have available for auditors. And some of those things are making sure that when you are running your reporting out of your EHR incentive, your EHR, to do your attestation, which essentially is, at that point going and, plugging in your measures for each of the menu and core objectives and clinical quality measures that you followed, that reporting coming out of the EMR, when you do that report, print it out. Do a screenshot. Do screenshots of anything that you think might just be a good backup to have as proof that you're achieving meaningful use. Make sure that you're tracking the software version numbers that you're utilizing. And understanding, again, any of the policies that relate to those audits so that you know that you need to have available. So not to scare anybody, but realistically, you know, CMS is doing these audits for a reason, because they want to make sure providers are doing what they say they're doing. So in those particular cases, there have been a number of cases where CMS has mandated that the providers return their incentives, not just for the portion of the incentive program or stage that they might have dropped a ball on or didn't have documentation for, but for the whole entire incentive program. So something to keep in mind for that. But as long as you're documenting what you need to document, you should be fine.
Okay. Kristen, we have a question that has been submitted. It's kind of a follow-up to this, what the providers can expect as in the way of audits to the incentive program. Is there any idea, any projection of how much provider time this will take?
For the audits specifically, or to achieve meaningful use? Do you have a sense of what that question's asking?
It has to do with describing the certification process, how, by whom, how much provider time does it take? I'm thinking the certification process here, and maybe more of how much time is it going to take to get the physicians up and reporting on the meaningful use?
You know, if we're going to talk about it in terms of time to allot to upgrade, train, and get your providers up and running on meaningful use, our recommendation and what we've been talking to our clients about is give yourself a full quarter to upgrade your software or implement new software if you need to make a change. And obviously, if you're implementing new software, you need to add more time to that, because there is all of the time associated with implementing a new EMR and then also training your providers on the new meaningful use requirements with your new EMR. So those are all things to consider in terms of the implementation process for how long it would take to get up and running. And the 2014 incentive program, again, as I had mentioned, providers need to complete 3 months of meaningful use. That meaningful use needs to be completed within a calendar quarter. So, you know, starting January 1st, April 1st. The meaningful use, those 3-month windows need to be completed within a particular quarter. And then you attest at the end of that quarter to be able to secure the incentives for meeting meaningful use the previous quarter. So, you know, even with our clients, when we were talking to them in December, and we had a number of clients that said, well, I'm ready to go, you know, we want to get upgraded, we want to start January 1st as our first calendar quarter to report meaningful use. And we have to have the hard discussion with them and say, you know, from a coaching standpoint, is this realistic? You're going to upgrade your software. You need to allow the time to train your providers. You need to allow some time to make sure that your providers are getting all of the either changes to the stage 1 or the new stage 2 requirements. So we've been coaching our clients to give them a quarter to get upgraded, make sure the training's in place, and be checking in to make sure that their providers are doing what they need to do. In our particular software, we have real-time reporting where you go in, you set up a provider for meaningful use incentives. Each provider can be doing different menu objectives. They all have to do the same core 7, you know, same core measures, but they can be doing different menu objectives or tracking different clinical quality measures. So it's important to be able to go in by provider at any time and be able to look at that reporting and see where they're at, who might need coaching, who might need assistance, so that you're not assuming throughout a particular calendar quarter that all of your providers are going to be perfect at meeting meaningful use. So just some guidelines there.
It's going to take some time. Okay. All right. Last question that we're going to have time for before we're going to close out the webinar. And any that we didn't answer, we will follow up with you individually. The last question that we'll have time for is what's coming down the road with stage 3?
And yes, as I mentioned, the incentive program is broken out into different stages meant to build on each other. Stage 1 focused really on collecting the data. Stage 2 is focusing on really starting to aggregate that data or pull it together and be able to slice and dice it. Sharing the data more across providers and patients, and then being able to make decisions with it. But stage 3, the focus is, it's expected, while they haven't outlined the rule for stage 3 yet, or the meaningful use requirements, the expectation is it's going to focus on really now starting to use the data to now really start improving outcomes and being able to make decisions. Now you have access to data for all of your patient base potentially, and being able to mine some of that information and data out of there to make better care decisions, and putting some guidelines into what are some different measures that you might want to look at for different patient populations to help make decisions for care, maybe on diabetic patients or something along those lines. And stage 3 is also looking at providing patients with increased ability to self-manage some of their own health care. What that is kind of yet to be determined, but we expect that there might be more of a reliance on teleradiology or remote monitoring tools, things that might be available to providers to take some of the burden off of seeing patients in the office, and really give the providers better electronic data to work with.
Okay. All right. Well, I do want to thank everyone for their time today. That's going to wrap it up for this webinar. Kristen, thank you so much for the information. MDeverywhere will continue to offer topical information in these webinars to help you improve your revenue cycle management process. If you would like information on ways to improve your clean claims submission rate and improve your practice's cash flow, by all means contact MDeveryware by emailing questions@mdeverywhere.com, or go to our website at www.mdeveryware.com and fill out the Contact Us form. Contact Kristen at Henry Schein, MD, for more information on the 2014 EHR Incentive Program, as well as practice management and EMR applications that are offered by MicroMD. We will follow up, as I said, with any questions asked but not aired on the webinar individually. A link to today's recorded session will be emailed to all registrants, and we encourage you to review it and share it with any of your peers. We would like to invite you to watch for announcements for upcoming webinars. Our next two, next week on February 27th, focus on payment reform and credentialing top 10 mistakes. Our March topics are going to be on the GEMS crosswalk for ICD-9 to ICD-10 codes, and we're also going to have a webinar on the HIPAA omnibus ruling. These events are posted on the MDeverywhere events blog, so just visit that blog page at www.mdeverywhere.com to register for these upcoming sessions. Kristen, thank you again. This is a difficult topic to attack and to really understand. There's so many pieces to meaningful use. So I appreciate all the great information. We thank you to all our attendees for spending time with MDeverywhere and MicroMD today. This will end the webinar. Enjoy the rest of your day.